All righty. Good afternoon and welcome to Sam Houston State University's College of Osteopathic Medicine October CME offering. My name is Rachel Erickson. I am the Professional Development Coordinator here at the College of Osteopathic Medicine. And today we are in for a real treat. If you're able to join us today, we are offering CME credit, and our presenter today is Dr. Kevin Lord, currently serving as the Associate Dean of Biomedical Sciences and Associate Professor of Pharmacology here at the COM. So we'll welcome him. Dr. Lord has joined us here at the COM since 2019. He helped to launch our medical school and implemented the first medical scholar summer program to support the first-year medical students' summer research experience, initiated an infrastructure plan to support future extramural funding, and contributed to the development of novel method of curricular blueprinting and mapping. A little bit of background about Dr. Lord. He received his doctorate in philosophy, pharmacology, and experimental therapeutics, and his master's of health science and physiology at LSU Health Science Center in New Orleans, Louisiana. Some of his previous works include working as an Associate Dean of Clinical and Applied Science Education for the University of Incarnate Word School of Osteopathic Medicine and Assistant Dean of Student Affairs at the Fike School of Pharmacy. He's also served as Director of Cardiovascular Core and Director of Experiential Affairs at LSU. He has held a variety of teaching positions, including at Louisiana State University Health Science Center, University of Texas Health Sciences Center, and the University of Incarnate Word School of Osteopathic Medicine and the Fike School of Pharmacy. So before I hand it over, at the conclusion of our presentation today, I will provide an assessment link to everyone in the webinar chat. And at the end of the assessment, it will redirect you to claim your CME credit. However, you don't have to remember that or worry about it now. I'll also follow up with an email later in the day. And so without further ado, I'm going to present and share our screen for Dr. Lord to begin his presentation.
Thank you very much. So let me see, can we?
Well, all the screens are going crazy again. Let me try one more thing. How's that?
So I see it as the note. Okay, there we go. Can everyone else see what one slide is application of evidence-based medicine? Can drop that in the chat.
Yes.
Okay, great. All right. Well, thanks for giving me the opportunity to talk today. And before I get started, I was told that I have to make sure that I read the conflict of interest page. So I have no conflict of interest related to this presentation, and I have no relevant financial relationships with any commercial interests relative to the subject and nature of this presentation. So no conflicts of interest on this side. I will be trying, let me see if I can do this. I'll try to monitor the, I'll ask Ms. Erickson, if you wouldn't mind monitoring the chat to let me know if anything pops up, because I'm not able to see the chat on my side.
Absolutely.
Thanks. So today we're going to talk a little bit about evidence-based medicine, and I don't typically like to kind of read the objectives, but it kind of sets the tone for the remaining of our session today. And it's also important to note that this is going to be one in a series of sessions talking to EBM. So the first thing I'd like to do is define evidence-based practice and evidence-based medicine, exactly what it is and what the context of it is. And oops. Jumped ahead on me. Sorry about that. Discuss the application of evidence-based medicine and how we use it in practice today, as well as the beginning stages is to formulate a clinical question using the classic PICO framework. And as we talk to that, also categorize the clinical question in its proper domain. And I put that as part of PICO, because as we move further into talking about evidence-based medicine, and we're talking about the acquire as well as the analysis and the application, the making sure that we use the right type of evidence becomes very important. So the right type of evidence for the right type of question. All right. So it'll take me a minute or two, and hopefully by the end of this, I will not be jumping ahead too many slides at one time. Apparently my mouse is sensitive at sometimes and other times it's not. So what evidence-based medicine is not? I always like to start with this because sometimes I get confused. I have a tendency to think of an expert opinion as is it evidence-based medicine or a statement in a textbook or guidelines. So as I think of an expert opinion, because I've been doing this for 5 years, I've been doing this for 10 years, does it make it evidence? And the answer would be no. And the same for a statement in a textbook. The one thing I can think of is guidelines. When I think of ACLS guidelines, and the first time I ever taught ACLS, I was fortunate enough to have a dual-boarded surgeon, an anesthesiologist, tell me that when I asked what the next drug he should be giving, he said to me, "Do you have any evidence that that drug works? I will continue to give epinephrine until I run out." And that's when I realized not everything in a guideline or everything in a textbook was supported by evidence. So the rest of these, it's no different. What's the latest paper in a prestigious journal? I'm sure that we've all, in our time in training, have had someone try what the latest maybe method, treatment, diagnosis was because it was in a prestigious journal, to find out that maybe it did or did not work. But at the time, definitely did not have enough evidence in order to support either the cost or the actions. And then talking to the traditional approach, the way we've always done it. So again, kind of the expert opinion. I've been doing this for 10 years, and this is the way I've always done it. Whether it's the antibiotic that might be prescribed, or I'll just use the drug in particular that I may have been interested in. Now, I did see a hand come up. I'm going to pause to see if there's a way for me.
I'll take that back over, Dr. Lord, and fix it
Okay.
for you. And really quickly in the chat, if you would like to unmute yourself, if you'd like to ask a question, or we can save our questions for the end for the sake of time. And then Dr. Lord, I'm going to give you have your control. So if you want to get back to it.
Okay, great. I can't see the question, so what I'll do is I'll wait till the end, and I'll try to make sure we have enough time in order to answer those questions. So as I talk to what evidence-based medicine is not, I always like to make sure that I put things in perspective. I'm a big fan of history and understanding the whys and the why nots. And talking to the way medicine was practiced 20 to 30 years ago and talking the way it's been practiced in the last 5 years, they're very different. And the evolution, as we look for the past and as we kind of will move into the present, the way that we had previously looked at it, the study and understanding of basic mechanisms of disease were the principles in guiding clinical practice. Combination of traditional medical training and common sense was sufficient, and then content expertise and clinical experience are sufficient base which to generate valid guidelines. And then when we read the papers, those that we would use for practice to update us, the introduction and the discussion sections were most appropriate and oftentimes thought as being adequate and sufficient. And I will tell you that all of these are pieces and parts to the way medicine had been practiced, and left gaps in continuity. I would say had led to maybe the reasons or the support for value-based care. So there was more consistency in the way we delivered care, because where you were trained had a lot to do with the type of medicine that you practiced. And evidence-based medicine tries to remove that, showing that evidence is the best way to to kind of put your foot forward in either the diagnosis, treatment, or management of your patients. So try and do one slide. Oh, darn it. Okay. There we go. So before we talk to what evidence-based medicine is, I just wanted to kind of give a brief history of some important individuals and landmarks. And the first I like to start with is blinded trials, because it's terms and where terms come from. And the first blinded trials were back in the 1800s, looking at using magnets for treatment of diseases. And what they did was they designed an experiment where they blindfolded the individuals and put magnets or just plain pieces of metal in front of them and asked for the impact or the effect, and showing at the time what they were measuring and the role of magnets in those particular disease that they were interested in didn't have any true effect. And that's where the term blinded trials came from, because they literally blindfolded the individuals. And as you look back through medical history, you'll find that a lot of the terms we use are related back to very specific events, which when I can, I like to point out, just because I think it's kind of cool. So as we move forward and we talk about how we got to where we are today, the primary person or the primary individual that is responsible for what we consider to be evidence-based medicine now is Gordon Guyatt, and he coined that term. If I try it maybe 3 times, I might get it right. Coined that term back in the early 90s, 1991, 1992, and he talked about how to best practice medicine at the bedside. And we'll talk to some of those principles in a minute. But in addition to that foundation of practicing medicine at the bedside, Archibald Cochran and Ian Chalmers are also critical in valuable steps and processes that we use in evidence-based medicine or evidence-based practice. Archibald Cochran was very much, Dr. Cochran, the Cochran Library is now shortened to just Cochran, looks at systematic reviews and meta-analyses, and has been very much a part of the vetting of the research that's currently in the literature. And we'll talk a little bit later about filtered and unfiltered information, or filtered and unfiltered data. And the filtered data is which has been tested or has been reviewed with very specific and strict standards. And he had kind of started that back in the 60s and 70s. That's what he's best known for. Now, how he came onto the scene, which I think is quite interesting, and why I mentioned Cochran and then Chalmers to follow, is that he had published an article called Effectiveness and Efficacy back in the early 70s. And it talked to the effectiveness, the efficacy, and then the quality of healthcare. And the effectiveness, looking at how much a technique or an intervention changed outcomes, the efficacy being very much how much it was incorporated, whether it was incorporated or embraced by the medical staff. And then the equality was the value base to the cure. So how much does it cost us, and I'm not talking just financial dollars, I'm talking in services, I'm talking in access, I'm talking in equipment, the entire component of what we consider the financial aspects of any intervention. So it kind of changed the way we started to look at things, and kind of brought a lot of evidence-based medicine to the forefront. And then Ian Chalmers is responsible for starting what was initially the Cochrane Library, now is now known as Cochrane, is the collection of all of these systematic reviews. So just a little history on from the 1800s and blinded trials to the evolution and challenges or first voices heard to evidence and using high quality evidence, to the practice of medicine and best quality evidence at the bedside. So what is best practice and what is truly evidence-based medicine? So it is a combination of, I call it the three-legged stool, and I call it a three-legged stool because that's how I was trained and taught. Be clear, I want to make sure that as I say this, as I was trained, I am a PhD and not in a DO or an MD. I do have a clinical degree, so I oftentimes when I talk to this, I think back to my clinical days in critical care. So I want to make sure that I appropriately represent myself and my experience. So as I think to this, it's the clinical judgment, it's the relevant scientific evidence, and then the patient's values and preferences. And it's critical that we talk to all three aspects. I don't want to say that there's any one that is more important than another. It is all three that are critical anytime you do render any type of judgment or care. So your experience, your clinical judgment, absolutely important. Relative scientific evidence, and when we talk today to PICO and the initiation of the ask, it is the quality of the evidence, the type of question that you ask that is also very important. And at the end of the day, as we move and we shift, in the next slide, I believe will doesn't talk to that. Actually, it's the slide after that. We'll talk to the importance of considering our patients and their values and their preferences, because no matter what the evidence tells us, and no matter what your best clinical judgment has been in the past and is for this particular patient, that if we do not align those two pieces to the patient's values and preferences, then it's for a not cause. The adherence to the program or to your treatment that you prescribe for your patient it will not exist. They will not follow it. Or if they do, it'll be modified, and they may not share how it's modified because they don't want to disappoint, or they're afraid to let you know that they're taking it every other day, or they're taking it on the third day, or they're not taking it all, that they're giving it to their cousin who needs it more. So it's important we kind of link all three of those together as we talk to true evidence-based medicine: your clinical judgment, the relevant scientific evidence, and then the patient's values and preferences. Now, what I'm not going to talk to today, I just kind of allude to, is what you see here with the quality of evidence. And as we think of evidence-based medicine, we always think about the highest type of evidence as being the best evidence. And what I will tell you, that as we move through this session today and have this conversation, that a meta-analysis may not always be the best evidence for your question, nor systematic review. Depends, maybe or maybe not a clinical guideline. And all of these, as I said earlier, are considered to be filtered because they go through a very specific process of analysis in order to determine or to rate them as a meta-analysis or a systematic review. But randomized controlled trials or cohort studies or case series, although they are lower on the evidence, depending upon what your question might be, may be better types of evidence for your question. So and my point to this is that as we talk to these three legs, that the highest level as we see it on the pyramid may not always be the best or the relevant scientific evidence for your patient or for you to make an appropriate decision. Now, I'll be honest, I forgot that I put this in here. So this is simply giving you a written form of the definitions, which I previously described. I do that sometimes for myself or for you, the viewer, so that you have this at a later time as a reference. So I'll pause to make sure that it's there. Why I didn't skip it, but it's something that you can go back to and always review. So if you talking to a clinical judgment, patient values, as well as relevant scientific evidence, written definitions. Okay, so the new paradigm, as we talked about the old, let's get to the new, to where we are today. Studying and understanding of basic mechanisms of disease are necessary, but are insufficient guides for clinical practice. We need more than just those basic mechanisms. The rationales for diagnosis and treatments from the basic pathophysiologic principles may in fact be incorrect, leading to inaccurate predictions about the performance of diagnostic tests and the efficacy or efficiency of treatments. Understanding certain rules of evidence is necessary to correctly interpret literature. Talking to causation, prognosis, diagnostic tests, and clinicians should be able to critically appraise the methods, results, sections of journal articles. I would tell you that as we look at the environment that we are in academia, and it's been this way for a while, that you publish or you perish. There are times when I will tell you that it does not matter the journal, that the data is sometimes suspect. The way they've designed the experiment, and I can give you an example. I will not use drugs or companies, but I have read those in the past, which was used to support a particular drug for FDA approval. You know, there've been times where they've compared it against a control or the gold standard, and the gold standard might have had a half-life of 8 hours, and their particular drug may have a half-life of 12 hours, and they were making critical measures every 10 hours. So it will absolutely look better than the gold standard. I think the best that I had ever seen, I apologize for chuckling because it's not funny, was that what they took the side effect profile of a particular drug and compared it against control standard. And the side effect in question of the gold standard was actually a detrimental side effect. It was absolutely something to be cautioned about in use and or when you prescribe. But the way the company phrased it, and they didn't lie, it was just that it was a misinterpretation or a missed opportunity, I guess you could say, was that they said that based on this particular side effect, that the gold standard was actually less than their drug. So they're pointing out that their drug is more detrimental in this particular, when evaluating this particular side effect. So it makes it sound as if, okay, you know, that it may not be as good as, or may have this side effect, but that it's kind of softened when you look at the gold standard. Well, in fact, the gold standard, as I said, was a problem. So not understanding or incorrectly interpreting the literature led to a drug that was on the market, leading to numerous deaths prior to it being pulled. So my point is that we have to be better at all of these when we are evaluating the literature, when we're trying to find what's the best evidence, the best intervention for your patients. So as we now move to the actual hardcore components, many of you have probably, if you're familiar with a little bit with evidence-based medicine, you may have seen these steps in the past: the ask, the acquire, the appraise, the apply, and the assess. And today we'll talk to the ask, and in the future we'll talk to the acquire. And the acquire is really about how to get to the best evidence. And I will tell you that no matter the training or the comfort with evidence-based medicine, when I talk to my colleagues and I ask them a clinical question, they oftentimes will go right to Google. And part of the acquire is knowing that there are other alternatives other than Google. And that is for a conversation at a later time when we talk to the acquire. And in the appraise. The appraise is understanding the data, understanding the statistics and how they applied the statistics. What was the study design? Understanding the study design becomes very important for you as a clinician, because if I'm treating an 18-year-old patient and the only evidence that I can find in the literature is looking at individuals between the ages of 50 and 75, I have to take into account a number of other factors because of the age difference. If I'm looking at kidney function, or if I'm looking at liver function, if I'm looking at maybe their ability to survive a particular treatment, age would become a significant factor. So appraising the literature has a multitude of, for lack of a better word, caveats. So we think about it, and we think about the rigor, and we think about randomized controlled trials. But I will also tell you that understanding all aspects of the literature becomes very important. And in my career, the study design has become probably one of my biggest focuses, because we all know that the statistics and the analysis is important. So we've done a better job of making sure that they align, but sometimes the study design is missed. And then the apply and the assess. So applying it and then assessing those outcomes. So again, the steps in the practice of evidence-based medicine, and today the focus will be on the ask. Now, as we talk to this, I can't help but to drag some of these other components of EBM into the conversation of the ask. I will tell you that this morning I spent 9 minutes changing the first 3 slides 4 different times. And it's because it's very difficult to talk about just one aspect of evidence-based medicine. And as I talk to the ask, without touching or mentioning the other pieces and parts. So as we move towards the ask, the first question is always, what is the value added for evidence-based medicine? I didn't talk to this in the history, but I'll mention it just a little bit now. I had used the word value-based care. I talked about effectiveness, efficiency, and equity. And I have a tendency to grab on to those words when I think about EBM. I get very excited about EBM and how to best apply it to our to the patient, because I think that no one patient is the same as another. That in your time, I think everyone has come to realize that we have guidelines for a reason, but it's the nuances and the 5% that I always talk about whenever talking to our students. That is why you make the big bucks. And that's where the evidence comes in. Understanding what's there, understanding what's best for your patient, and also understanding your resources. Today, as we see we have certain patients that have excellent insurance, and how you go about diagnosing or treatment is not a question. And then we have a very large group of those that there's a significant inequity amongst or within our system, and they don't have access to either the same types of tests and or potential management. So as we talk to evidence-based medicine, I also like to tie it in and talk about value-based care, in that when you use a resource, it is a resource, whether it's a diagnostic test or it's an intervention. And if there isn't a reason to be doing it, but you feel as if you need to satisfy the patient and they feel as if they walk away with something, or it's the way you've always practiced, medicine, I would ask that you question that, because we are limited in our resources when it comes to healthcare. So evidence-based medicine and the practice of using evidence in care does give or can give a significant value added to the way we manage our patient, remembering all three aspects of that stool, all three legs. So one of the challenges we have is the complexity of the literature. There's just so much out there. And the next couple slides, I want to kind of point that out. And I point that out because I always get pushback on the ask from the students. So it's so easy. I don't understand. It's easy to ask a question. And I would tell you that what you put in is what you get out. And that's pretty much anything we see in life, right? If I eat garbage for lunch, well, then I get garbage as a result of that. I may get headaches, weight gain, and anything that and everything that may come from that. So how do we manage the literature? So I wanted to kind of give you a couple quick points that I pulled out, kind of giving you some background on what is out there in the literature when it comes to what works and what doesn't. 2007 analysis, I know it was a while back, 2016 systematic reviews from the Cochrane collaboration. 44% of the reviews concluded that the intervention was likely to be beneficial, 7% likely to be harmful, 49% did not support either benefit or harm, 96% suggested that they required further research. So I'm going to let that lead into the next slide, which is the amount that is produced every day. The amount of articles, biomedical, Medline, trials, as well as diagnostic that you see every day. 5,000 per year on the biomedical side, 2,000 being added to Medline. To put it in perspective, we're looking at over 2 million for the year, upwards of over 500,000 on the Medline side. And then you have the trials as well as the diagnostic. It's impossible to read all of those. You wouldn't be able to bill for anything. You wouldn't be able to feed the family because you'd always be constantly trying to keep up with the literature. And I'm not saying that you don't read in your particular area. What I'm telling you and what I wanted to do was to kind of show you the sheer volume that we are producing today. And part of it is our fault, right? The publish or perish. You need to keep moving things forward. And it doesn't always mean that we have quality work, which is one of the concerns and that Cochrane has taken up. So what does that look like when it comes to practice? Well, about half of valid evidence today is out of date in 5 years, and half of valid evidence is never implemented. One of the things, it's somewhat outdated. This was probably, I'll say 11 years ago, because the numbers that I'll use, I'll talk to being within 10 years. That's the findings that impact clinical practice, that could improve clinical practice, often took upwards of 10 years to make it into practice. So from the time it made it into the literature to the time that you saw it or recognized it as part of common practice took upwards of 10 years. Part of evidence-based medicine is to try to shorten that time. And there were a number of reasons that it took that long. One being physicians weren't aware, they didn't accept it because it may have contradicted their current practice. It may not be applicable to their patients, or they may not understand how to apply it. So there were a number of reasons for that. My point is that we look at the sheer volume of evidence that is produced, and we talk about what had been, as I said, 11 years ago, because I don't want to mix the 10 and 10 up, but that previously the challenge had been that it took a significant amount of time from the time it was published to the time it was actually being used. Evidence-based medicine helps shorten that time, because part of what we're going to talk to is the ask, and how do you channel and focus that ask. So what skills do you need in order to be able to keep up, to be able to utilize best evidence, to find the evidence more efficiently? It's incorporated into the 5 asks of EBM, the 5 A's of EBM, to appraise the quality of evidence more effectively. So you have to be able to understand the methods and then the result sections. It can't just be the introduction and the discussion. You have to be able to go to the nitty gritty and the why am I going to use this, and then to use good quality evidence more systematically, so that when you find it and it has been shown, it has been proven, that you then take that evidence and apply it across a greater breadth of patients, not just those that have the better insurance, but find ways to use it for everybody that it should be used for. So I think I've said the ask on a number of occasions now that I don't want to keep repeating myself. So where do we start? The ask. So again, the steps that we talked to: the ask, the acquire, the appraise, the apply, and then the assessment. Today, we're going to focus just on the ask. So let's talk a little bit about PICO, a couple examples, and how we can better fine tune our ask so that we can better utilize the evidence that is in the literature in order to meet the needs of our patients. So the PICO framework: a good clinical question must identify and consider particular pieces of information about the clinical question and our situation. And I'll kind of reiterate that as I talk to the question, developing that question. The details, the devil is in the details. So the PICO framework, which I'll talk to the acronym in a minute, is critical for developing this clinical question. And what does PICO stand for? Patient, intervention or exposure, comparison, outcomes, and there are times when time could be a factor. It could be critical to your answer. Is exposure of 3 months, or exposure of 1 year, or recovery of 2 weeks from a concussion, or recovery of 6 months from the recovery of a concussion are acceptable. So time can absolutely be a factor. We don't always include it, but I want to make you aware that PICO can be expanded to PICOT. So let's talk a little bit about the clinical questions. I'm keeping an eye on the time. I like to make sure that I don't go over. So I'll try to keep this to the next 7 to 8 minutes. That way, if we have any additional questions, and we have time for that, or I give you a few minutes back to your day. So clinical uncertainty: evidence-based answers for patient care. Clinical questions often come to mind in a form that makes finding answers in the medical literature a challenge. When do we most frequently use these concepts of evidence-based medicine? Is when it's either outside of our training or comfort zone, wheelhouse, as I like to reference it sometimes, or it's the ask of the patient. So you might be very comfortable in what you would want to do, but the patient, him or herself, presents with some very unique challenges or unique asks. So how do you go about finding the answer in the medical literature? Then dissecting the question into its components to facilitate findings. The best evidence is a fundamental skill. So I always like in class to kind of put up an example and then ask for examples. And it's amazing at the beginning of a course when the students will start with something that is so broad and so wide that there is real no answer to their question. But through practice and through practice, that what happens is that they find that niche knack to narrow their questions, and by narrowing their questions, they then get the answers they look for. And the first times for this often come as a result when they hit that enter button for their search and they get 12,000 articles. I can't review that. So you have to refine that search and refine that search and refine that search to get what you want. And the way you refine that search is asking an excellent question. So let's talk to the different types of questions. So as we talk to evidence-based medicine, and we'll do a couple examples in a minute. Understanding the type of question will become important, because my next slide will not just talk to the type of question, but then it'll talk to the type of study that best answers the domain is best suited to answer your question. So therapy, diagnosis, prognosis, prevention, ideology, or harm are the classic ones that you will typically see when people talk to or describe the type of question in regards to evidence-based medicine. Therapy being which intervention results in the best outcome, and probably the one that is most used. I can tell you that it's the one that I most frequently refer to. Diagnosis, which test is the most accurate in diagnosing a condition. I oftentimes use that to talk about sensitivity and specificity, why you would have one test first versus another. Prognosis determines the clinical course over time, possible complications of a condition. So as you're talking to your patient and you talk to what direction you want to go in treatment and or management, prognosis becomes very important. Cost becomes very important. Quality versus quantity of life also becomes very important. Today, prevention is always a big question. How can I prevent? How can I reduce my risk of the development of a particular disease? My family has a history. What can I do differently? So determining how to reduce the chance of condition. And an ideology or harm, determining causes or risk factors of a condition. So if I'm a professional football player and I have 3 concussions, am I worried about cognitive effects later in life? Well, what does the evidence show? 1, 2, maybe all it takes is 1, or maybe it's a buildup over time. So go to the evidence to determine. So as we talk to the domain, and we can talk to the study type. So as I said earlier, that the therapy is probably the most common, the intervention. Randomized controlled trials are most frequently.
Welcome to Duo.
Hello? Was that a question?
No, I'm sorry. You're good, Dr. Lord.
Oh, okay. Sorry. Because I can't see anyone. It was a little weird, so I apologize for that hesitation. So therapy, randomized controlled trials, cohort, case control, case series. As you look at the quality of the evidence. Now, I don't want to dwell too much on going through each one of these because I am starting to run up on time. But what I want to make a point of is this: is that if you can't find the evidence for, and I'm going to use intervention in a randomized control trial, if you find it in a case control or a cohort, does it mean that it's not valuable? And I would tell you absolutely not. I would tell you that there's always pieces of evidence in all aspects of these that you can use in treating and managing your patient. You have to understand the study types. And again, that's for another time, but understanding those study types so that you know which pieces or parts of the evidence is most important. What do they control for? Or more importantly, what they do not control for. I personally have a tendency to always go to a limitation of a study. So that if I know what it can't tell me, then anything I take out of it, I can use. So as you talk to these different types of domains, and as you develop a question, then understanding the value of your study type becomes very important. Okay, so a couple quick examples, and then I'll open up the floor for questions. So what I have here, and for just because for time purposes, I'm not going to read this, but I give you an example, specific example with a significant amount of detail, and then I go through and actually break down what the PICO is. So the patient, and in this case, the age, men versus women with memory loss and low education, the intervention, or not the exposure, but the intervention, comparison, as well as the outcome. And I know this is being recorded, and you can always go back at a later time and actually read through it and see if you can identify the specific PICO components. But what I want to do before I stop talking and allow for questions is to kind of give a couple broad examples and talk about how you can, you're looking at your patient, because these are oftentimes questions that may come to me from students, sometimes colleagues. I can talk to you evidence-based medicine and how we can use this in identifying the best treatment, or in identifying possible harm. But I also use the same concepts when I talk about research and focusing a question. So to give an example of, does physical activity at school reduce the risk of obesity? Very general, very broad question. So how can I focus that question? So we're talking school-age children. Do I want to look at elementary? Do I want to look at middle school? Do I want to look at high school? If we talk to school, do we want to look at college? So being specific in who you might be evaluating. If I'm looking at, in this case, I realize it's obesity, but I'm going to use asthma as an example. So individuals below the age of 8 versus greater than the age of 8. There are differences in their development and potential severity and the diagnosis of that could be important. When we talk to cognitive changes, then we're now looking at puberty as a potential impact. So the specific patient you have and what you look at and how you write that question will then set up how you search for that answer. So I may not just want to look for, does physical activity reduce the risk of obesity? I'll be getting a wide range. So somebody who's 50 years old and is obese is going to look very different than somebody who is 12 years old, 18 years old, or 25 years old. So adding that additional detail of your specific history and physical findings of your patient. What is the effect on physical activity is the intervention. So define the physical activity. I might be looking at children that are autistic. So I'm not able to, depending upon where they are on the spectrum, may not be able to engage them in certain types of activity. So what if we just talk about walking? What if it's the amount of steps that they take every day versus no steps? Again, my point here is to kind of give you an example of when you ask this question, and general as it may seem, focusing it, making sure that you actually write it down and break it down according to the patient, the intervention, the comparison group, and the outcome becomes critical. And as you go through these examples, the P's, the I's, the O's, and the C's are not necessarily in the appropriate order, because it was the way that I may have approached it. So you'll find that they are kind of scattered throughout. Does early exposure to smoke increase the risk of esophageal cancer? So I'm looking at individuals that have cancer, and then I'm going backwards in time, ideology, to determine the cause or risk factors of the condition. They have to have my group. I have to have a group with esophageal cancer, because now I'm looking at the impact of smoking. Early exposure. So is it me smoking, or is it secondhand smoke? So these are all things that I would want you to consider as you develop your questions, because the more developed your questions are, the more succinct your ask is, the more time you put in, the better your outcome is going to be. I won't get 12,000 hits. I might get 40 hits, 20 hits. In a very busy day where I'm seeing 20, 30 patients, then it becomes more manageable to be able to go through that evidence as opposed to 12,000. Okay, with 5 minutes left, I'll go ahead and stop at this point and invite any questions. Thank you.
Okay, we will stop our share. We do have the chat open. It was disabled before. I've had a plethora of technical difficulties today, so my apologies there. But I am super appreciative for Dr. Lord to present today. And yes, please go ahead and drop any questions for him in the chat. If you aren't comfortable asking questions or would like to ask your questions at a later date, we will go ahead and put our email address in the chat, excuse me, so that we can make sure that any of your questions do get answered at a later date. And then I will also take just a quick second to drop our claim credit link for you all. And that way you can claim your credit. And again, if you don't feel like you have time today, or you're running 2 rounds or a class or something like that, look for an email that will provide you all of that information with your claim credit that you can do later. So any questions in the chat at this time? Okay, I'm not seeing any questions at the moment, which is totally fine. Again, our email is in the chat if you'd like to follow up later. And I will go ahead and drop our claim credit link in the chat in just one moment. Get this for everyone.
Yeah, I'm sorry.
No.
I was to say you're welcome to the thank yous. And again, this is it's a series, so each one builds on the other. And then they're all interrelated. So as we have additional conversations, hopefully we wind up with a better understanding of how to. I think one of the biggest challenges is efficiently accessing the information. So thank you again for the opportunity to talk about evidence-based medicine.
And we hope to invite Dr. Lord back for future CMEs. So if you are hoping for that as well, go ahead and fill that out in your assessment. Our next CME offering will be November 10th from 12 to 1 p.m. at the same time. And we'll be having our guest speaker is Dr. Kevin Kalinowski, talking a little bit more about robust narrative feedback for our preceptors. So please join us again next month for our November CME here at the SHSU College of Osteopathic Medicine. Thank you, Dr. Lord, and thank you all for attending. Have a great afternoon.